I'm Prof Pinkney, I'm Professor of Endocrinology at the Peninsula Medical School and the University of Plymouth, and I'm a physician in the National Health Service. Well, the striking thing here is that over the last century there's been a complete change in what the principal health challenges are. So we've moved from a situation a century ago where healthcare was dominated by infectious diseases and diseases of poverty and malnutrition, to a situation where those have been largely conquered in most parts of the world, not completely, but largely. Over the last half a century, we've been confronted with a completely new set of challenges, and this has come about as a result of a gradual increase in body weight of most populations in the world, and this has been a major driving factor behind a whole host of chronic diseases. So, for example, in the UK at the moment, we know that 2/3 of the population are now overweight, and of those, about half can be defined as being obese. Now, obesity is a pretty serious issue. It's often been dismissed, not taken seriously, but it really does impact people's quality of life and many of their opportunities in life, and leads to a great burden of physical and mental health. And of course, the approach of healthcare has been to pick up the pieces from that, to treat the complications of it, whereas we really lacked any tools to address the primary problems of weight gain. So we tend not to be able to prevent weight gain, we tend not to treat it when it's occurred. We weren't born like this, so very few of us are actually born overweight or obese. So this is clearly a problem that comes about because of the environment that we live in and the choices and lifestyles that we lead. For example, yesterday I was speaking to a lady who'd had her second stroke. She's relatively young, she's been left pretty severely disabled by this, so lifelong care for her and to support her family. Why did she have the stroke? Well, she had raised blood pressure and type 2 diabetes. Why did she have raised blood pressure and type 2 diabetes? Because she was severely obese from a young age. Well, why was it that we didn't treat the obesity when she was younger so that she didn't go on to have the stroke? So this is a typical example of our complete failure to actually engage with the root cause of the problem. At lower levels of overweight and obesity, I think that these are common issues that people grapple with some success on a daily basis. But from a health service point of view, it's very, very difficult when people reach very high levels of obesity. This is a very, very difficult disease to treat. We just don't have the tools to get a handle on it at the moment. There are some potential options. Clearly, surgical intervention is one, bariatric surgery. It's applicable to a relatively small number of people and not everybody wants it. But that is not an intervention that you would really want to deliver for millions of people in the population. So this brings us back to what actually causes weight gain in the first place, and it's behaviours that drive this around food and physical activity and lifestyles, and really that's where the money has to go. If the health service is going to offer people some hope of a useful intervention that's going to be effective, clearly the question arises, what's that going to be? And one of the problems at the moment is that the evidence base in this area of medicine is really severely lacking. There's quite good evidence around bariatric surgical intervention, and there's some emerging evidence around drug treatments. But at the present, the NHS doesn't really understand how best to implement behavioural change for people with severe obesity. We think that severe obesity is an under-recognised problem. There are probably at least 5 million people in the UK with a body mass index of over 35 who could therefore be defined as severely obese. So that's a far bigger problem than many other common diseases that we've all heard of, and yet we don't actually have a joined up strategy. One of the big evidence gaps at the moment is in understanding how to configure interventions for weight loss for people with severe obesity in the health service. And the research team has come together to investigate an idea that group-based behavioural treatment may be a more effective and sustainable way to support people with severe obesity to lose weight. There's been very little research on this subject before in the United Kingdom, and not that much anywhere else in the world, so I think that the significance of this health challenge is recognised in the fact that NIHR supported this programme grant to the tune of £2.5 million over the next 5 years. So the PROGROUP project is about behavioural change for people with severe obesity It's about gathering the evidence base for this intervention. It's about understanding current interventions and how they can be optimised, and how specifically you bring people together in groups for facilitated group-based behavioural change. The programme also involves a feasibility study, randomised controlled trial, and then a full national randomised controlled trial of an optimised programme for group-based behavioural change.
My name's Dr Swancutt. I'm a Senior Research Fellow and I'm the Programme Manager for PROGROUP. PROGROUP is a group-based intervention for people who have severe obesity, and we've been working closely with frontline service staff, clinical colleagues, patients, and drawing on the evidence base to create something that's really robust and meets the needs of people. So it will be running over 5 to 6 months. We'll initially start running at 3 centres, and then we'll move on to working with another 10 centres nationally. We really hope that it taps in to the peer support that people gain in groups. So it allows, by having the group setting, it allows a facilitator to support a group of people and for them to support each other. And it also, it takes advantage of the clinical contact. So rather than a person might have 4 hours of one-to-one contact with a clinician, rather than the 4 hours of individual contact that 12 people might have, you can really compress that into much more efficient use of clinical time and better clinical contact for patients. Because obesity itself and long-term weight gain we're finding out it's much more complex and really difficult to reverse. And so a really narrow research approach wouldn't work for us. We've got a multidisciplinary team, and by that I mean we're working with qualitative researchers, we're working with implementation scientists, we're working with health psychologists, we're working with clinicians. So bringing together those different approaches to develop the intervention, to do the randomised controlled trial, to run a process evaluation alongside that, to give really uncover some of those fine details about what happens in the care context. It really brings a whole lot of benefit. And we haven't pretended that finances aren't an issue for us, so it's not in an economic vacuum. We've got some really cutting-edge health economic analysis, and that'll help us to articulate what the costs are associated with this, how we're using our NHS resources now, and how we might use them in the future. I just think that this is a fantastic programme of work. It's really exciting to be part of. It's a wide team of the different disciplines coming together, and I'm excited to be overseeing how the research comes together and having a really practical outcome, a really practical piece of research that we can share with others.
So this programme of research has really benefited from the involvement of patients and frontline clinical staff from the outset. So ultimately we really hope that this will be an intervention that's relevant.